Good afternoon and welcome to the virtual care panel. I think the Health Connect team saved the best topic for last, and we're delighted that you guys have stuck through the afternoon to learn more about telehealth and the value surrounding telehealth and virtual care. I'm honored to share the stage this afternoon with three amazing people who have a wealth of knowledge and information when it comes to virtual care. Claudia Douglas is principal at PricewaterhouseCoopers with over 25 years of experience with healthcare strategy and operations. Her expertise is around the care models to more ambulatory and virtual settings to improve consumer experience. She co-leads the firm's new model of care and the virtual care telehealth offerings. So welcome, Claudia. Amy Burney-Preddy is the Director of Revenue Integrity with WakeMed Health System in Raleigh, North Carolina. She's responsible for the overall enterprise process and revenue improvement and supports over 1,400 healthcare providers and staff as it relates to practice operations and process improvements. And then Jeff Robbins is the director of the Neuro and Sleep Lab and the Telehealth program at Tift Regional Medical Center. He implemented this health system's first telehealth program around 13 or 14 years ago, and he's developed innovative methods to grow and expand their telehealth offerings. He works closely with the community partners in an effort to build an inclusive telehealth program. And I'm Sherry. I will be your moderator today. I am the Chief Operations Officer with the Global Partnership for Telehealth. Partnership for Telehealth is Georgia's largest and oldest nonprofit telehealth provider, and we've been serving Georgia for nearly 20 years with the goal of connecting people with the healthcare that they need. So as we all know, with our traditional brick and mortar healthcare practices came to a screeching halt very suddenly one day in March. And that was the springboard for virtual care. It really launched virtual care into the mainstream. And now time has elapsed. I'm getting a horrible echo. Maybe if we're not speaking, maybe mute ourselves. That may help. Let's try that. Okay, I think it's gone away. Sorry about that. So maybe now, since COVID has happened, we've had enough time to kind of take a look in the rearview mirror to synthesize the virtual care and its value and what role it has truly played in healthcare thus far. In today's panel, we're going to look at how well virtual care is done, where is its value, and what happens looking forward. And to be perfectly honest with you, when we're talking about virtual care, sometimes it's a challenge to talk about it only in the terms of dollars and cents. So today's panel will talk about it not only from a monetary standpoint, but also a human standpoint and the value that it has brought to our residents and our communities. So I'm going to start the discussion today with talking to Jeff a little bit about his program. As I mentioned in the intro, this is old hat for him. He's been doing telehealth for quite a number of years. And they've been a leader in the South Georgia area in terms of virtual care. Jeff, can you tell us a little bit how virtual care was used prior to COVID and how has COVID shifted that? What are you guys doing differently now?
Well, I think you would be the first to agree that we've been doing this for close to 15 years, and you actually know our program as well as I do. And during that time, we've had tons of success. You know, and a couple of our successes pre-COVID that come to mind is our telestroke program. What an amazing program that really affects people's lives in a positive way. Simple connection to some neurologists in Augusta. Our relationship with Emory's kidney transplant team. We developed Emory, the first pre and post-op kidney transplant clinic via telemedicine, and just an amazing gift to be able to tell a dialysis patient that they don't have to drive 500 miles round trip to meet with their transplant team. And maybe I think probably a program we're the most proud of, and that's our schools that we partner with to develop school-based health clinics. And the list goes on and on. But for every success pre-COVID, God knows we've had a ton of failures. Programs that we thought everything was in place, the right team, the right champions, a champion on both ends. Very rare do you have a champion on both ends. a process that we have complete ownership with of providers, mid-levels, physicians who are so excited about adding this to their practice. And then when we went live, the program just never got off the ground. It just never worked the way we wanted to. But what we didn't know at the time was that for every success, and maybe more important, I think our failures made us 100% ready for that day in March 14th to be exact, when COVID hit our town. So just real quick, let me tell you some of the key points that I think made us so ready for when COVID came. At that point, we already had a full inventory of units, scopes, cameras, stethoscopes. We've for years have felt that it is better just to have this equipment on hand than scurry around and figure out, how we're going to order it, when we're going to order it, and how long it's going to take to get to us. What have we developed in our 15 years of doing telemedicine? A well-seasoned staff that is really prepared for anything in the world of telehealth. And I'm reminded when senior leadership called and said, okay, we need to have some units in the ER, we need to have some units in the ICU, we need to do this, we need to do that. The staff was like, we're already there, we're already doing this, we're ready. And that was just a nice feeling to know that we are prepared and there's really no panic. And I think the most important key to our readiness was our wonderful partnership with our telehealth network provider, which is Global Partnership for Telehealth. At the time of March 14th, our entire corporate footprint was already completely networked with telehealth. So there was no scrambling around to get the network up and running. We were already ready. We had a relationship in place for the last 15 years. Our liaisons were in place. So it was just a wonderful transition to our daily telehealth routines to more of a panic, but we really didn't panic because we had everything in place. So let me just share a little bit about how we've utilized virtual technology when COVID hit. Probably the first thing I noticed was our providers that historically refused to take part in any form of telehealth. They didn't want to hear about it. They didn't want to see it. All of a sudden realized that this stuff works. And it just didn't work, but it worked really well. And what they found out is it kept their practice opened. Second, it allowed some of our older patients or older providers who were very, very nervous about what was going on with this virus. It allowed them to stay completely connected to their patient and continue to see patients every day. Virtual appointments have allowed our physicians just to stay connected with their patients at a time when a lot of our community, we're in South Georgia, and a lot of our community is elderly, overweight, a lot of diabetes, a lot of heart disease, and they were scared. They just didn't understand what was going on. So it allowed us to continue of care, the continuity of care. It allowed our providers realized early that it wasn't going to be safe for, again, a certain segment of our population to come to their office. So virtual care allowed their patients to still be seen when needed, but it also allowed them, we got to remember, this is going on for 8 months. So it's allowed that patient to share new health concerns with their provider, concerns that weren't emergencies, but really needed to be addressed in a timely manner. I think one of the wonderful parts of this last couple of months is the loosening up of the regulations due to COVID. That was just huge for us. And I think the whole world of telehealth. The relaxation of the regulations allowed our physicians and staff to educate the patient about maybe a new onset of a chronic disease, medication management, mental health visits, for the first time could be done from home on a smartphone or a tablet. And that was kind of magical for us. And let me just say this real quick. I have no idea how long the eased restrictions will last, but this newfound popularity in telehealth will definitely put pressure, I think, on the systems, the government, the insurance companies, and just our healthcare institutions. They've realized that we must continue to push this telemedicine. It's not going to be an option. it's the future is here, and it's going to have to be a major option. We also utilized it. Virtual care completely cut out time spent in a waiting room when there could be potential contagious patients. But I'll tell you another thing that I hated. It took the pandemic, but the pandemic forced us as an institution to look at our home monitoring capabilities, and it just showed that we need to increase our capabilities. And as we entered this time of uncertainty, that included really a complete shutdown for almost 2 months of our facility. Our patients with chronic diseases still needed to be followed, and it was really nice to know that with the use of an internet and some really simple devices, that we could still monitor blood pressure, glucose levels, lung functions, heart rates, and even sleep patterns on really simple devices that all really fall under the term of telemedicine. And probably the most important thing that happened once COVID hit was it allowed for us to keep our critical care physicians safe. And what we did from the moment we locked down our hospital, we placed a telemedicine unit in every single COVID room. If we deemed it a hot room, they had the ability to connect. So on March 14th, when we locked down our facility, we had at that time only 2 critical care pulmonologists on our medical staff. And this allowed them to stay safe. It allowed us to put a machine in a room. It allowed the nurses to go in and out of the room, but it allowed that physician, who we really couldn't afford to lose for 14 days, let alone get sick. It allowed them to stay out of the room. And really, that's just kind of a quick overview of some real game-changing changes in telehealth that happened once COVID was in our community.
So Amy has a slightly different perspective and experience with virtual care and telehealth. WaitMed didn't have a telehealth program prior to COVID, so it all hit. Amy, sorry for you. I bet it felt like you were drinking out of a fire hose for a long time, and maybe it still does. So from a healthcare system and from an experience of going from 0 to full speed, what's been your experience with virtual care, and where has WaitMed been able to find the value in virtual care?
Yeah, thank you. Can you all hear me now?
Yes.
Yes.
Okay. Speaking of virtual care, I've had nothing but tech issues all day, so happy that we got this worked out at the last minute. So yeah, prior to COVID, we had one surgeon doing post-op visits for his patients, but then COVID hit, and we started talking about stay-at-home orders, and our physicians and our leadership knew right away that we had to start, walking down this telehealth path. And I really think what helped us was just always rowing in the same direction, keeping our mission, vision, and values at the forefront of what we're doing. And that's always having the patient and family first. So, almost right away when we had the stay-at-home order put in place, myself and one of our primary care physicians were asked to kind of lead the charge and go from no telehealth to a full telehealth program. And it was just a lot of communication, a lot of meetings with physicians, leadership, our IS teams, our marketing teams. We identified lots of questions that we had to ask and answer. Would our providers buy in? Would our patients be able to do it? Are they interested? Do we even have the technology resources? So, to echo what Jeff said, our providers, their main concern out of the gate was, how do we keep our patients safe? How do we keep them healthy? How do we keep giving them the care that we're here to give them? They were so concerned about not being able to deliver care and our patients, having long-term effects from that. So from the provider standpoint, while we had some who were nervous about the technology and nervous about this method of care, because it's not anything that we had really talked about before, they were bought in. And then with all of the payer changes, we just were rapidly, I had some great team members who became rapid telehealth experts, and they were providing updates to everybody who needed updates, but we made them the coding experts and took all of that worry off of our front end providers. But our IS team, man, they just buckled down. They knew that we had to make sure our patients could get care. And within 2 weeks, we went from not having a telehealth platform to having telehealth for all of our providers and specialties. And that was an amazing feat that we are still so proud of them for. And then I think, we started during that 2 weeks where they were building, we were practicing. We had a telehealth champion team where we were meeting with them, teaching them everything that we knew. We had them do a see one, do one, teach one method. So they would join us, we would show them, they would go back to their teams and practice, and then they would teach their colleagues. So going from 0 to 1,500 visits in 2 weeks was only possible because we had so many people willing to jump in and help out and teach others, which was really exciting. And then our patients, I think that was kind of the last check with the help of our PR and marketing team, who were making sure that our instructions all were the same, whether it was Televox or MyChart or us calling them, that we were giving consistent instructions out. We were making videos for our patients. We were reaching out, telling people how to download apps and things like that. We're in a pretty tech-heavy city, but most patients in our area were not used to this method of healthcare. So this was new for all of us. And I think just being able to check the box for all of that and knowing that our doors were open for our patients and they knew that we were here for them, that has made a huge difference. And we've had a successful program since then. So it's been really exciting.
And Amy, I'm guessing at this point, you and your team are pretty tired. I know what it takes to stand up a telehealth program. And usually when you're planning, you're thinking well in advance. So my hat's off to you and your team for accomplishing that very lofty goal. But Claudia, I kind of want to turn over to you now. You come at telehealth and virtual care from a much broader standpoint. And as you're working with clients to evaluate virtual care, what kind of value points to determine?
Yeah, great question. And I'm actually
Claudia, I believe that you may have muted yourself by accident.
Oh, sorry.
Here you are.
There we go. Thank you. Yeah, the value. So actually, I was just answering one of the comments in here. Ned had asked about patients kind of, obviously we saw a big rush of patients, especially like you were saying in mid-March, 80 to 90% of volume direct to consumer, whether it was primary care, especially in virtual. And then it's kind of, 6 months later, we're seeing about on average by service line, in total, about 25%. But some specialties are higher than others. So behavioral health is particularly high and has been a great specialty for people to use even before COVID, right? And I think we'll continue to see those high rates because you don't often need to touch the patient. And in fact, some of the studies have shown people are more amenable to share things about themselves that they hold close to them on the video versus in person in the same room. So the value, I think, is absolutely there. I think we probably have a lot of people watching that either have used this for themselves or a loved one. And we're seeing great provider satisfaction, like Jeff was saying. There are bumps in the road. Sometimes technology doesn't work, or you have to get some of your processes, your pre and post processes right. But on average, providers really like this. Patients really like this. There are some things I think that we're seeing shake out that probably aren't the best for virtual. And it's like we've been thrown into this agile pilot really quickly, right? And so we're learning a lot. We've seen too some providers doing some innovative things. For example, still doing virtual with the with either the NPPA or the physician, but also sending somebody out to the house. Maybe if someone's blind or they want to lay eyes on someone, they're concerned about other issues that they need to do a physical exam. So they might send an EMT or somebody that you would have in the office that would kind of do your pre and post before your physician comes in out to the house. So there are all kinds of different models going on right now. A lot of innovation, which is exciting. And as Jeff and Amy were saying, we're kind of watching what's happening with payment. Each state is different, and being in Georgia, a lot of you, are watching that. We're watching it from a national perspective. I also think the election's going to determine some value, right? And what the depending on who wins, how they'll support this. Medicare, everyone's watching that, and a lot of times commercial follows Medicare. We're also helping some clients with their budgeting and their ROI on this, because if you're going to invest more, right, and you're going to train more and do some different things, because there's the direct-to-consumer piece, there's also the tele-ICU, tele-ED, all the remote patient monitoring, and some of the other specialty to specialty, remote second opinion type business. And as you're looking at that, we've also helped some providers prepare to discuss this with their managed care companies. And as you know, those in risk, higher risk situations, we're already using virtual, especially those vertically integrated delivery networks where they were paying for care and providing it in the same company. So they, some of those advanced networks have been through this. And of course, then your own employees, right? So you're at risk for them. So a lot of times people have dabbled in that early on to test some of their pilots. So I think there's a lot of value in it, and it's an exciting space to be in.
I agree with you more. And when I talk about virtual care, I kind of talk it at a three-legged stool a lot of times. It's a win-win-win. The health system wins because they're able to provide more appropriate care in a more appropriate setting. The patient wins because they can receive care in their community or in their home or someplace more local. And then the payer usually wins because they're not having to pay the high cost of emergency care. I'm just curious, and I'll throw this question out to all three of you guys. What has been the experience in your system in terms of being able to address a patient in a more appropriate, maybe lower cost setting? How's that impacted how you've started using virtual care?
I'll take that. We already have a mobile clinic that travels to the areas where the migrant farm workers are working, church parking lots, a lot of into the lower income areas, and we just felt, and that's a service that we just offer to those people. Telemedicine has just revolutionized that, because it's allowed us to keep that mobile clinic going even when we don't have a provider. It's allowed us to connect back to a provider that maybe had some open slots. So in times where that mobile clinic would have been canceled for some reason, this has allowed that mobile clinic to go back out with a presenter and present back to a physician that had some downtime or had some appointment slots open. So for us, it's allowed us to help that needy community in just another way. The mobile clinic is amazing, but just to add telemedicine to it has just made it that much better.
I would echo, we have a similar experience at WakeMed. We do a lot of.
Oops, I think we lost her.
Had some terrible technical difficulties this afternoon, so maybe she'll pop back in and be able to join us again. I wanted just to quickly address. I saw Ned's question also in the comment section. I had a very interesting conversation just a couple of weeks ago with a medical director in a very large health system up north, and the conversation was all about the dollars and cents around virtual care. And as soon as kind of the fever pitch of COVID hit, and then sort of we got a little bit comfortable, things started opening back up, our state started to phase back in openings, and some of our brick and mortar healthcare practices began to open up again. His health system, they realized very quickly that they were more profitable when their doors were closed and only virtual care was open, because the no-show rate was so low. They were actually having people come in, and so the compliancy was there. So I thought that was a very interesting take from someplace outside of Georgia that had not been doing a lot of virtual care prior to COVID, but turned almost to 100% after that. So as we're thinking about virtual care, and I know we're still in the middle of a pandemic. I heard a very wise speaker earlier today, and I can't remember who said this, or I would give credit, but they were saying that COVID isn't hopefully a forever thing. Hopefully we're what, 6 or 8 into it at this point in time. Hopefully we see a leveling off and a back to normal, whatever normal is going to look like after all of this. When we're thinking about virtual care, And Claudia and Jeff, from your experience, do you see virtual care remaining a part of the mainstream healthcare system in general? And then, Jeff, specific to you at Tifton, and if the case is yes, you do think it's going to be long-term. Sustainability, what does that look like? There's a lot of questions right now. Is CMS going to allow for a lot of these current waivers to change or to stay? What is the state of Georgia going to do? It's really, everybody's kind of waiting with bated breath somewhat to see what's going to happen. So, what are your thoughts? What's sustainability look like?
Yeah, I think, Sherry, so I would say it's here. It's just at what parity level, right? And so I think we'll have to watch for that. Like I was saying, the regime, what ends up happening in the election this fall, we're watching that very closely. We're going to publish some guidance on that from our Health Research Institute. And I'm on that panel and we're working on that right now. Also, I think consumer demand is going to be really important, right? And health systems also, speaking up and saying, our providers really like this, our patients really like this, we need to move forward. So I think, and there are going to be some things you're going to want to go physically in for. I do think we're going to be in this for a while. Some are saying mid next year or end of next year. By the time everyone gets vaccinated or that doesn't, and we get herd immunity. But I would say we're going to be in this for a long time. And as you know, with change, once you're doing something for 6 months, 12 months, 18 months, it really gets more and more cemented. There's also a lot of movement, a lot of disruption. And if it does save costs and it increase access and quality, and like we're seeing with some really vulnerable populations, especially with social determinants of health, I think we're here to stay. It's just specialty, and how does this function with the economic model for reimbursement?
I agree with all that, and I would, and kind of to answer Ned's question also tied in. I view this in a very simple way. In 1940, nobody knew what a drive-in was. Okay, everybody cooked at home. Well, guess what? Now the majority of people pick up their food through a drive-through or have their food delivered. This convenience isn't going anywhere, but that's going to be up to us. We're going to have to drive this. There is going to come you just can't see your physician forever on a smartphone. Okay, I'm a real healthy guy, but he needs to look at my ankles for edema. We need to make sure there's not a gangrene toe. Is there an ingrown toenail that's looking bad? Somebody at some point needs to lay eyes and hands on patient's entire body. So that direct-to-consumer model is not the end all, but that there is a piece of that where for years the statistics have said 65% of all family practice encounters can be done over the phone. Okay, well that means you don't need to touch that patient. So I can see that direct-to-consumer model continuing to grow. But I also think, I'll tell you an example. Yesterday, we had a gentleman in the neuro lab, and he said to the neurologist, he said, "Can you give me my answer?" And she goes, "Well, your appointment is tomorrow." And he goes, "But I drive 2 hours to get to Tifton." And she said, "Well, I have to put your stuff together, your answers, and you're going to have to drive tomorrow to see me." And this would have, the same fee could have been charged, but for that, there was no reason why to go over an MRI, to go over a sleep study, to go over a nerve conduction EMG, to go over blood work could not have been done virtual. And he would have been happier. That's the perfect time for that physician to be thinking about that. It should be in her practice. Her staff should be thinking about that. Hey, doc, this is the perfect patient to be presented in Adel 50 miles closer. So I think we have to play a huge part in keeping this in the forefront and seeing how it works in our model. But I agree with Claudia. This is not going anywhere. People say it's the future. No, it's the current. The future is here right now. This is it. This is the Jetsons, 1959, when Elroy was seen on a TV screen by the doctor. I use that video all the time. That's here. It was real in 1959, and it's real now.
So Jeff, you brought up a really salient point about the patient's there, the provider says, "Well, you've got to come back tomorrow." The patient is now in a conundrum. Oh my goodness, I've got to drive 2 hours back to have maybe a 10-minute long conversation with you. One of the things that I've heard time and time again, the technology for the most is there. The bandwidth for them, Amy may disagree with this statement, but the bandwidth for the most part is there for most people. It's boiling down to a lot of education, and education with the patient to even know to inquire about telehealth. And there is education with the providers to know that, hey, this is something that we can provide. There is reimbursement around it. We do get paid for it. There are the dollars and cents that make it feasible. So what is a health system? And now, Amy, you're back with us. I'm hoping you can hear us now. But I would like to throw this out to the three of you, and maybe Jeff, you grab it, and then maybe if Amy is able to hear us and communicate, maybe she can grab it next, and then Claudia kind of tie a bow on it. But what are you doing, Jeff, with your health system to educate those providers, to let them know, hey, this is there. It's a feasible way to provide health care, and you're going to get paid for it. I think the payment piece has always been a question. So how is TIF addressing that?
Well, I mean, I think our providers knew that we were big into telehealth. They just, some of them refused to use it. And we still have physicians who are not, it wasn't part of their training. They want to be in the room. I understand that. If I was a rock star with a band, I'd want to be in a live audience, not playing virtual. You want to be the rock star, and that's what they are when they walk in the room. But they're seeing that they also, whether they buy into this virus is real, but they're not afraid of it. I'm not afraid of it, but it is in the back of your mind that they don't want to get sick, or they've already been sick and don't want to get sick again. Why would we not offer this? And when you talk about educating the physician, the provider, the patient, how do we educate the patient? The patient's never going to understand this. Well, I go back to, if anybody has an 80-year-old parent who said they would never use an iPhone, they didn't go to a class. They didn't take a course, and no one came to their home. And all of our elderly parents are now experts on smartphones. I know mine are, and I'm not sure they know what day it is, but God knows how to get on Facebook and how to communicate and pay their bills. The patient, they figure this out. They figure it out, I promise you. The physicians are the same. They see that there's no choice. I sometimes make this very simple. I say, if you see a follow-up, I think all follow-up should be virtual. There's really no reason, if you touched the patient a month ago, they don't need to be touched in a follow-up just to review results. It should all be done. The government needs to pay for phone calls. I said, just the fact that the patient is not in your office, they're not flushing your toilet, they're not using your Kleenex and your toilet paper, you're not having to clean as much stuff, is a savings right there. This, and when this is over, there are still going to be people scared to death of a healthcare facility. So that physician has no choice but to accept this is here and it's not going anywhere.
I'm not sure if you were able to hear the question earlier, but we're talking about education being a barrier in adoption of telehealth. What is WakeMed doing to get your physicians and your staff prepared and to continue to offer this, if it's something that WakeMed plans to continue with?
Yeah, absolutely. Just making sure you can hear me, right? Okay, we'll try this again. So we, since day one, we have continual, like I was saying earlier, telehealth champion sessions. And what that is we basically had our leadership in each service line or department choose a provider, whether an MD and or an APP, some of our clinical staff, our front office staff, and we have about 100 telehealth champions throughout our physician practices. So we try to meet with them monthly. And myself and Dr. Holly in our primary care department, we're always available for questions. But we really, every month, just try to go over what's new, issues that we know to have happened over the months, changes that we've made, upcoming changes, get their thoughts and feedback. So we try to have an open line of communication with that whole team. We're pretty tight knit, so everybody knows kind of how to reach each other, and everybody is welcome to speak up. And we have a direct line in partnership with our RIS team. So when we're having technical difficulties, they're right there to help and troubleshoot. So I think that's been really important. We've also identified a really robust toolkit that we keep on our intranet internally that has videos and instructions, and if it's how-to videos or instructions for providers and instructions for our clinical staff and instructions for the front office staff. So we've got a lot of resources that are readily available to everyone. And it's just a talking point. It's something we don't let die in conversation. We keep bringing it up. So it's always at the forefront, especially because this is going to be a big part of our strategy moving forward. So we want to make sure that everybody is, continuing that conversation.
Yeah.
Do you have anything to add to that?
Yeah, sure. I was just going to add, I think both Amy and Jeff said, even the phone. So we have a client that has a pretty high Medicaid mix, and they were able to, they had a 50% no-show rate pre-COVID by using, and a lot of the patients are just calling in on the phone, but they're staying connected, they're staying on their medicine, they're, it's been fabulous. So it's really important for social determinants of health, decreasing costs for the country. Feel very strongly about that, and working through. One of the things we're doing right now is we're helping a health system work through all the different service lines. And like Jeff was saying, what makes sense, pre and post for some. How do you do this? How do you make sure that your flows are right? What a lot of people are calling your digital front door, that patients know how to get in the lobby and wait, and streamlining all of that. So there's so many different process pieces that need to be worked out as well. I think that's really important to improve the health of the country.
So we've got about 5, 6, 7 minutes left of this session. I just want to kind of have just an open discussion with you guys. And we'll start with Amy, and we'll go Amy, Jeff, and let Claudia close out. But Amy, what closing words, comments, words of advice, and words of wisdom do you have for anybody who's trying to do virtual health in a meaningful way?
Yeah, I think for us, we just knew it was the right thing to do. So when you're facing this challenge of something you've never done before, I think we just kind of dove in. And our biggest strength as a team was just remaining flexible. And I think that my word of wisdom or advice for folks, trying to embark on telehealth or will soon in the future is you've got to remain flexible. Things are not always going to work. Obviously, technology is not always our friend. Payers are going to change. Your strategy might change because of that. But I think the bottom line is we're all here to make sure patients can get healthcare, right? And we don't want to see long-term implications of patients not getting the healthcare that they need. So if you keep that at the forefront of everything that you're doing, and just know that you're going to have to roll with the punches, and you're going to have to tweak and change things as technology evolves and as payers change their rules and as you get new folks in. But always having that open line of communication between your teams. And like I said, just being willing to kind of dive into something new and ask a lot of questions. That was our other biggest strength. We weren't afraid to ask questions, and sometimes we got the answers wrong, and that was okay. But I think together as a team, we were just able to move past all of those. And then I think the other part of it, and I alluded to this earlier, is really just teaching our patients, because it's not just our struggles internally, right? It's getting our patients used to this new kind of healthcare, which for some are very used to it. And like I said earlier, in our market, they just weren't. This was not something everybody's used to coming into the doctor's office. So I think my other part of advice would be having a strategy around how to teach your patients how to use the technology. So we are trying to, at every touch point, when they're in our office or when we're calling them on the phone, do you have the app? Do you know how to use it? Can we help you? Making sure that they have all of those things in place so that if we have stay-at-home orders again in the future, or even for those who, have to stay home because of school, and we're homeschooling children now, and all of these barriers that we have that we didn't have before, we want to make sure that our patients can easily access us. So I'd say, again, strategizing how at every touch point you can teach your patients how to use the tech And then what all is involved with that. You know, we're on Epic and use MyChart, all of the great features, refills and notes and all of those features that patients are just unaware of. So I think right now one of our biggest strategies is taking the time to us understand the technology and everything that it offers, and then teaching that to our patients.
Thank you. Jeff, parting words.
My parting words. So I think we will, as an industry, as a healthcare industry, we're going to see telemedicine expand throughout the world of healthcare in ways that I think we never could have imagined pre-COVID. But I believe if we're going to really see this happen on a grand scale, I think we need to be extremely realistic on what is our expectations. What will we expect as our immediate return on our investment, and what do we expect on the future return on our investment? I've come to realize that, speaking for my group of senior leaders, everybody has a different expectation on what their return on their investment should be. The CEOs is different than the COOs, and the CFOs is definitely different from the chief nursing officer. But what I have found over the past 15 years, I have found that if you truly believe in this technology, and it's really very simple technology, but if you truly believe in it, and you put it in place for one sole purpose, and that is to connect somebody in need to someone who could help, and you're basically just improving a patient's access to your quality healthcare, your facility, everything will fall into place, and everybody's expectations will be met if you put the patient first. That's my parting words.
Thank you. Claudia, would you like to tie a bow on our panel?
Oh my gosh, sure. That's a tough act to follow there, golly. So totally agree. I think putting the patient first, and I've been able to see this from other countries' perspective too, because we're helping some other countries because they're looking at us and saying, wow, you're farther ahead than us. We were all on the phone, and even now we're still all on the phone. And how do we evolve? So I think kind of looking at that global view too. I mean, other countries are looking at us to take the lead on this. Denmark is doing some really exciting things and has for a long time, but we're being watched as well. And so kind of leading in global healthcare is important too. And I agree, putting the patient first, and it will follow. And really, I think any lobbying efforts people can do, talking to your local government, and those efforts are really important. Staying connected with payers and showing the value, I think, is really important in keeping this at the forefront.
Claudia, you mentioned something a few minutes earlier, that you were on a board, and I didn't catch the name of the board, but you said there would be a guidance coming out at some point in time with whatever the fallout is post-COVID in terms of what's going to be allowable and not allowable. For those of us who are listening and learning today, is there a place that folks can go and get that information, or how can they access that type of stuff?
Yeah, what I can do is I can send you, we'll be coming out with some guidance this fall. We already have some things I could share, some reimbursement guidance and other things, and then I could share kind of, we're watching the election, and I'm happy to share our HRI, our Health Research Institute reports.
Thank you. And I would be remiss if I did not add also that Georgia happens to be one of the 13 telehealth resource centers that are federally funded by HRSA and the Office for the Advancement of Telehealth. It's called the Southeastern Telehealth Center. It serves Georgia, Florida, South Carolina, and Alabama. So any of you who are listening in who need free resources and just anything telehealth related, check out the Southeastern Telehealth Resource Center. In addition to that, Georgia holds quarterly telehealth work group meetings, and it's just a casual place that everyone who is interested logs in. It's a Zoom call usually, and we share stories, and you learn from each other, and there's been some pretty cool innovative ideas and partnerships that's been a result of those work groups. So I encourage you to check out the Southeastern Telehealth Resource Center and make use of what is there. And with that, I would like to thank Amy and Claudia and Jeff for your time today and your expertise. Definitely have learned a lot from you today. And thank everyone and have a wonderful afternoon.
Thanks, Sherry. Bye, guys.
Appreciate
Thank
it.
you.
Have a good afternoon.